but evolving in many countries, including US, methadone has become the drug of choice for management of chronic pain because it allows persons to have a normal lifestyle, to think clearly, to perform clearly, and yet have excellent pain relief. And you can add short-acting opiates to add additional pain relief when necessary. The brain is changed by short-acting opiates on, off. And this is why we've now taught pain doctors to use sustained release medications or methadone or buprenorphine, which have long-acting properties, and not morphine on and off for most of chronic pain management. Because on-off effects acting at receptors disrupt molecular biology, neurotransmitters, and behavior. Same with cocaine, same with alcohol. Steady state, sustained release is essential to allow normalization of many functions. The other group that had studied methadone, but only to rapidly detoxify people, was the Lexington group, who gave methadone 2 to 4 times a day, usually 4 times a day, but often in centers reduced down to 3 or even 2, and had given it only over a 7 to 10 day period with the idea that it must be short-acting, that their goal was to get people off the opiate. Well, the first work was done in our hospital. We recruited people from releasees from prison, people that had finished prison, finished parole. Our patients had a mean of 14 years of addiction history. Addiction we defined as multiple daily self-administrations of the opiate, primarily heroin, every day for at least 4 years. Later we were to back off to 3 years, and later yet to 1 year. We would like to see that be reduced to 6 months or 3 months. It has not been any place in the United States or Europe. We also know in US, and I know it's true here in France, methadone is overregulated. You heard me ask questions about medical maintenance. Well, it really doesn't exist in any country except US and now Sweden. I was able to introduce it in Sweden. But after whatever the tolerance of acceptance is, once patients do well in methadone, then they may progress to medical maintenance, where the methadone is prescribed by either a general physician or a psychiatrist or a specialist in internal medicine. But the patient must come to a methadone clinic initially, and they must be attached to a methadone clinic in case problems arise. Now, when we developed that concept in 1984, we put very tough limits. We said they had to be in methadone treatment for 5 years. That's absurdly long. And now the criteria in most places is 1 year of successful performance. But even that is too great unless you have really fine methadone programs. Many of ours are, but some certainly aren't. And in France, I've been to some superior methadone programs, and I've been to some that are not so great, just like US. So I think in France and in US, we need to do 2 things. We have to decrease, not deregulate, but decrease the regulations on methadone to allow progression, change the fact that you had to have 1 whole year of multiple daily self-injections of heroin to get into methadone treatment. That also is too long. The concept of daily multiple injections is very sound. That should be the criteria for methadone or buprenorphine, not just DSM-4 criteria, which do not require a biological change, no dependence, no tolerance. Something in between is necessary for both. I think we should have equal access to methadone or buprenorphine. For induction, you would choose whichever would seem to be better. Somebody with a low degree of tolerance, fewer years of addiction, I would probably start with buprenorphine because you can move seamlessly onto methadone. And whenever I say buprenorphine, I mean buprenorphine naloxone, never buprenorphine alone. And then one can choose for people to start methadone, those that have years of addiction using very high amounts of heroin or other short-acting opiate, and they will do better. So the first work done at Rockefeller, and the second study was done as translational work 1 year later, but published earlier because of a reason I will tell you. The original work was done in '64 in 6 months, and Professor Dole wanted very much to present it as an exciting new finding at the most prestigious of the United States organizations for medical research, the Association of American Physicians, or Old Turks, as we lovingly call it. Then an organization of honorific type for men only, subsequently admitting women, and yes, I am now an Old Turk. Now, we looked at heroin addicts on the street, we brought them into the ward of the hospital, and what we found we show in this cartoon. Heroin addicts use heroin 3 to 6 times every day, as you see here with the peaks and valleys. If they don't use heroin, they will go into withdrawal. If they take too much, they may have an opiate overdose. We started the methadone dosing based on what Hood and Beecher had taught. We had the opposite goal, so we started with the 20 to 40 milligrams, which had been shown by Beecher and Hood to be safe in opiate-naive individuals, but then raised the dose slowly. And it was my obligation, amongst many other things, to observe the patients and see when they could have the next dose and have the next dose escalation. So we started giving 2 doses a day, and by the end of the first month, I talked Vince into letting me give it 1 time a day, building on the work of Hood and Beecher, and giving it 1 time a day with 10 milligrams increase per week until we reached dose of 80 to 120 milligrams. And when we did that, we saw persons that were not high or euphoric and not in opiate withdrawal, but in fact completely normal. And yet studies beginning in our studies in 1964 have shown that the majority of heroin addicts need 80 to 150 milligrams a day of methadone. So the buprenorphine isn't really quite adequate, because we do know that the top dose of buprenorphine naloxone, or buprenorphine alone, that can be used with increasing effects in humans is 32 mg sublingually. That's equivalent, and many studies have shown this, to about 70 milligrams of methadone. And some people are accepting that lower than adequate to be able not to have to go to clinic every day. We then conducted 2 sets of studies, each 4 weeks long, in a double-blinded Latin square design, in which we superimposed a short-acting opiate, such as heroin, denoted with this H, against the background of daily oral methadone. And what we found in the first study was that no one had a euphoric effect or a high. We then did a second 4-week set of studies, same design, Latin square, double-blinded, and what we learned again was people could not feel heroin or dihydromorphone or morphine. Morphine caused pins and needles, but nothing else. Heroin itself or saline. We then did a 3rd set of studies, and they are shown here. We superimposed against this background now of increasing doses and increasing duration of time, as you will see in the balloons, 20, 40, and 150 days of treatment. We superimposed up to 160 milligrams of pure Justice Department supplied heroin against the background of methadone, and found that once dose had been increased to that 80 to 120, and time had elapsed, cross-tolerance occurred so that one could not perceive or become euphoric from the superimposed opiate. These studies accomplished 2 things. They let us know that the former heroin addict, now in early methadone treatment, would not kill themselves if they would go out from the clinic and superimpose a short-acting opiate. Further, they taught us the mechanism, which we had hypothesized but had not evidence for at the beginning. That is cross-tolerance. Now, when that first presentation was made, we couldn't submit the data by early December of '64 because we hadn't finished going over all the data. So we had to wait 1 year, early December